Welcome to The Explainer. Today, we're going to take you right inside one of the most high-stakes moments in a surgeon's career, the oral board exam. We're going to role-play a classic case, stepping into the shoes of both the examiner and the candidate to really break down the kind of systematic thinking that separates a pass from a fail. Let's dive in.
Okay, the clock starts now. You're the candidate. The examiner has just handed you a scenario that's pretty common, but it could also be lethal. Look, the goal here isn't to just blurt out a diagnosis. It's to show that you have a safe, structured, and really comprehensive thought process. Your whole career could be riding on this.
Okay, so the very first thing I do is take a thorough and, very relevant history, and then follow that up with a complete physical examination. The whole point is to really understand the complaint, spot any red flags, and start building a mental list of what could be going on.
So when I dig into the history, the patient tells me he's had this on and off black stool or melena, but has gotten a lot more frequent lately. The fatigue and shortness of breath, well, that screams anemia from chronic blood loss. And that significant unintentional weight loss, that's a massive red flag. He hasn't been vomiting blood and isn't on blood thinners, which helps narrow things down. But the real kicker here, the thing that sets off all the alarm bells, is that family history. His mother dying of colon cancer at 59 immediately puts malignancy at the very top of my list.
Okay, moving on to the physical exam. Just by looking at him, you can see he's underweight and pale, which totally lines up with what we suspected about the anemia and weight loss. His vitals are stable, so he's not in any immediate danger, which is good. His abdomen feels pretty normal, except for a little bit of tenderness on the right side, right where the cecum is located. And then the DRE, absolutely vital. I can't feel a mass, but seeing that black stool on my glove confirms there's active bleeding. So right now, my working diagnosis, the number one thing I'm thinking of, is a malignancy in the right colon, probably the cecum.
All right, that's a good, structured approach. The question now is, how do you get from a strong clinical suspicion to a rock-solid diagnosis? It's time to lay out your investigation plan.
My next move would be to order a series of investigations. I've got three main goals here. First, to check on the patient's overall condition. Second, to see just how bad his anemia is. And third, and this is the most important one, to find the source of the bleeding and get a tissue diagnosis.
I'd start with some baseline blood work. Check his blood count to quantify the anemia, see how well his blood clots, and get a read on his liver and kidney function before we do anything invasive. But really, the main event here, the single most important test, is the colonoscopy. It's the only way we're going to get eyes on the inside of the colon and be able to biopsy anything that looks suspicious.
All right, looking at these results, one number just jumps off the page. The hemoglobin, 7 grams per deciliter, is severely anemic. This completely explains why he's so tired. This isn't just a minor bleed. We're talking about major chronic blood loss. The fact that his clotting is normal makes a bleeding disorder less likely and points us right back to a problem inside his colon.
And the colonoscopy, well, it gives us our answer. We see this large, irregular, what we call fungating mass. It has this nasty cauliflower-like look to it, right there in the cecum. This is the textbook appearance of a colorectal cancer, and it fits his symptoms perfectly. The very next step, while we're still in there, is to take multiple biopsies to get that definitive diagnosis.
And here it is in black and white. The pathology report confirms our worst fear, a poorly differentiated adenocarcinoma. Now, that term, poorly differentiated, is a key phrase for any exam. It basically means the cancer cells are really abnormal and don't look like normal colon tissue at all. This tells us it's a more aggressive tumor, one that's likely to grow and spread faster.
Okay, getting the diagnosis isn't the end of the road. It's just the beginning of the management plan. The examiner is now testing your ability to think past the diagnosis and into staging, which is absolutely critical for figuring out the right treatment.
My immediate next step is to stage the cancer. This really involves two key things. First, a blood test for a tumor marker called CEA. This gives us a baseline we can use to track how he responds to treatment. Second, and most importantly, a CT scan with contrast of his chest, abdomen, and pelvis. This scan is crucial for figuring out the TNM stage. Basically, how big is the tumor? Has it spread to nearby lymph nodes? And is there any distant metastasis anywhere else?
Wow. Okay, so the CEA comes back at 345. Just to put that in perspective, normal is under 5. This is massively elevated. A number this high often means there's a larger tumor burden, more cancer in the body, and it becomes a really important marker for us to watch.
So the CT scan confirms the mass in the cecum, and it shows enlarged lymph nodes right next to it, which are very suspicious for spread. But, and this is a huge but, the scan shows no evidence of distant spread to the liver, lungs, or anywhere else. This is fantastic news for the patient, because it means that as far as we can tell, the cancer is still contained to that one area and is potentially curable with surgery. This is the big one. The examiner wants to see a comprehensive management plan. This goes way beyond just the operation itself. It needs to include communication, teamwork, and the patient's entire journey. My management plan won't just be about surgery. It's got to be holistic and coordinated through what we call a multidisciplinary team. It starts with good communication and getting the patient ready, then moves to the surgery and includes planning for any treatment he might need afterward.
First things first, this case has to go to our colorectal cancer multidisciplinary team meeting. That's where surgeons, oncologists, and radiologists all weigh in and agree on the best plan. After that, it's about the patient. I'd sit down with him and his family to break the news as compassionately as I can and get his informed consent. The definitive surgical plan for this localized cancer is a right hemicolectomy, where we remove the right side of the colon and then reconnect the bowel.
A good outcome really depends on meticulous preparation. The examiner wants to make sure I have a safe and systematic checklist to get this anemic and malnourished patient ready for a major operation.
You bet. The pre-op prep is all about following a strict checklist. After he's admitted and we've gone over consent, we get him optimized. He's severely anemic, so he's definitely getting IV fluids, and he's almost certainly going to need a blood transfusion. We'll give him prophylactic antibiotics to prevent infection and medicine to prevent blood clots. After a standard anesthesia consult, we double-check that we have cross-match blood ready to go. Finally, we'll even mark a stoma site, just as a precaution, even though it's unlikely we'll need it here.
The exam case now just fast-forwards through the surgery, but the candidate's job isn't done when the patient leaves the OR. The examiner is now testing my knowledge of both the immediate post-op care and the crucial long-term cancer surveillance.
So my follow-up plan really breaks down into two parts. The immediate post-op phase, which is all about a safe recovery, and then the long-term surveillance, which is designed to catch any cancer recurrence as early as possible.
Right after surgery, we're all about an enhanced recovery protocol. This means getting him up and moving early, starting his diet as soon as we can, and making sure his pain is well controlled. We'll keep a close eye on him, pull out any lines or catheters early to reduce infection risk, and have him do deep breathing exercises to prevent pneumonia. The whole goal is a smooth, quick recovery.
That first clinic visit back, usually a couple of weeks later, is a really big deal. Sure, I'll check how he's recovering and look at his wound, but the main event is reviewing that final histopathology report from the surgery. This report gives us the final T and N stage. If it turns out any lymph nodes were positive for cancer, his case goes right back to the MDT to decide if he needs adjuvant chemotherapy, and then I'd refer him to medical oncology.
Now, long-term follow-up isn't just guesswork. It's totally protocol-driven. As you can see here, the surveillance is most intense in the first 2 years, with frequent exams and CEA blood tests. We'll also do a yearly CT scan to check for any distant recurrence and a colonoscopy at the 1-year mark to look at the surgical site and the rest of his colon. This structured plan gives us the best shot at catching any recurrence early when it's most treatable.
And that's really the take-home message here. Whether you're in an exam hot seat or standing in a real clinic, panic and taking shortcuts are your worst enemies. This case just perfectly illustrates that a calm, systematic progression from history and exam through staging and multidisciplinary management all the way to long-term surveillance is the absolute bedrock of safe and effective surgical care.